we will just start thyroid today. Okay. So actually, thyroid, no anesthesia exam is finished without having a complete grip of this topic. Okay, because they will be asking you in whether it is a long case or whether it is a table viva. Okay, or whether even if it is it's OSCE. Okay. So, if you want to start from where you should be getting the information about thyroid. So, actually, thyroid, you should be knowing about the anatomy. Okay. What is the levels at which different lobes of thyroids are there, like lobes, isthmus. Okay. What else? It's nerve supply.
Nerve and
It's
blood supply also.
it's like blood supply. Okay. Okay, so main points about the surface anatomy. What else? Then you should be knowing the physiology. Okay, for physiology, you should be knowing how thyroid hormone is synthesized. Okay, how it is controlled. Is its release is how it is controlled. Okay, so then effects. like we are just trying to make an idea but what are our targets, and we will try to cover as much as possible. Okay, so what are the effects, on the any on whole body? Okay, because thyroid hormone is the, you can say, the fuel which is controlling the metabolic rate. So thyroid hormone is very important in this perspective. So what are the effects of
The site of action, yes, also at
hyper and
cellular level. Yes.
hypo? Yes, how is the action? And actually it is because it is acting on throughout the cells of the body. So it has okay. So what else? Then effects of hyper and hypo, causes of hypo and hypo. Okay, and hyper. Okay, then what else? You should be knowing the decompensations. Like uh, at the end of the day, some effects or side effects will be minor. Okay, so main, what, like for example, if someone asks you what are the main problems of thyroid, so you can say there are some compression effects in the area and the hormone effect itself. Okay, that will be there. You can divide it actually in two group. Some will be only because of pressure, so it will be pressure on airway and pressure on the food pipe and windpipe. Okay, so make understand, it's very easy for you to understand in this way. Okay,
And yes,
so
excuse me, sir. We can also apply here three M's, like another mass effect and a
mass,
metabolic effect and
metabolic.
medication effect. If we continue the treatment, if patient is already on the treatment, then we also can discuss about the medication effect of
Okay,
thyroid's medication effect. Yeah.
okay. So, what will be the treatment? We said that we should be knowing what are the hyper and hypo effect of thyroid, and then how to treat it. Okay, and what are the acute complications. Okay, so if you are talking about thyroid, the acute complications may be thyroid crisis. Okay, and myxedema coma. Okay, so why this is actually, you are making a chart, you are tuning yourself that when you are opening the book, what thing you should be knowing about it. Okay, so in thyroid crisis we can further say that there is some metabolic effects, and there are some effects on the like for example cardiovascular system. Okay, there will be arrhythmias. So this is how you, and similarly, mixed edema coma is leading to hypofunctioning. Okay, it will be leading to even coma, like sorry, what do you say? Um, delay, decrease conscious level. What we say? Syncope. Okay, it may present as a syncopal attack. Okay, so like this is how you will be chalking out, making a scheme for it. Then very important effect will be, which is our anesthesia, is airway. Okay, so our main focus will be related to airway. Airway, not only distortion, okay, pressure and extension into the this one thorax. Okay, so retrosternal. So with relation to airway, the normal airway examination, as well as distortion created, the pressure effects, and the extension. Okay, so this will be our main focus when we are discussing about airway. And then what will be the effect on different steps of anesthesia, just like we always discuss with the same scheme, optimization. What sort of optimization we can get? Okay, then what will be the concerns in the preoperative period, like do we want some referrals? Okay, referrals will be usually we would like, for example, nasal endoscopy is one of the referral. Okay, endocrinologist is one of the referral. Okay, then radiologist, who is doing the thyroid scan, or they are who are doing lateral x-ray neck, or CT scan. Okay, so this will be one of the diagnostic as well as preoperative workup with what we are doing. Okay, so also you can say blood works is actually the domain with the endocrinologist, but blood works for TSH, T3, T4. Okay, and what else?
Thyroid
uh,
scan also
Thyroid
sometimes
scan
with
I have written here.
isotopes.
A thyroid scan,
Okay.
okay, isotopes, and then ultrasound. Okay, so this will be the preoperative workup which we are doing. Then, because some side effects will be because of the medications. Okay, medications, either we have to optimize as we discussed before, and or we have to continue, and we have to anticipate the complications uh, because of that medications. like just give an example, Jamil. Any example of any complication which you can see with, for example, carbimazole?
But carbimazole, there is agranulocytosis
Neutropenia
and
and
depression of the white blood
agranulocytosis.
cells.
Okay,
Yes.
so like this is one example I'm telling you. That then another thing is that you have to, if the patient has recently started, you have to wait for around 4 to 6 weeks for its effect. Okay, so then, for example, if there is some specific age group, you have to convert it to specific medication, things like that. You have to continue the medication. Then so this patient, which
Okay,
will
sir.
be, yes.
Yeah, just also like mixed edema coma, there is also need to start very low doses with the ECG monitoring. There we can
Yes,
get
yes.
the arrhythmia
Yeah, we
also.
will
Yeah.
we will discuss. Actually, I'm just giving you an overview at the moment. Just we
Okay,
should
sir.
be, because even, for example, if we know our enemy, it will be easy for us to attack it. Okay. So at the moment, we are just trying to, when someone is asking or thinking about what is thyroid, first thing to do is what, because everyone has studied, everyone knows about it. The problem is only that when we are asked a question, we are not able to identify why, because maybe we have not stressed on it. We have not given any stress on it that we it is important. So my purpose of this early discussion is that I'm just giving you an overview. What is the domain of this topic? And you will be surprised that it's such an extensive topic. Okay, still we a lot of things. Okay, so this is will be thing that, because just please mute. Okay, so then what will we be doing? At the end, like up till now, we have just say that we will be looking at the anatomy, physiology, how is the control, what is the pathophysiology, what is the causes of hypo or hyper, then what are the effects on the different systems, what are the acute complications. Then we evaluate the patient. We said that we will optimize the patient. We will be doing the preoperative workup, and then what will happen that we have to chalk out a plan of induction. Okay, because of challenge airway, it will be a problem. So we have a thorough airway management plan with backup of all the because of what will be the problem, that even front of neck access will be. This is different from any other airway management, that in any other airway management, at the end of the day, you can say that you can have front of neck access. Okay. But what will be the problem? That in this case, you are not able to do even to do the front of neck access. So airway management in thyroid is very important. Okay. So this is one thing, that how will you be inducing? You will be doing awake, or you will be doing inhalational. Okay, or you can do the worst answer which we get is rapid sequence. This is the terrible answer. Okay, because you may be ending in cannot intubate, cannot ventilate. Okay, so this is a dangerous scenario. So this is one thing. Then what monitoring you need? Okay, so special monitoring here, maybe in addition to standard 1 and standard 2 monitoring, you will have we discussed that there is a specific endotracheal tube with electrodes. Okay, which is monitoring the vocal cords, which is monitoring the recurrent laryngeal nerve. Okay, so this is one specific extra monitoring you can do. Other maybe temperature, like other not temperature in the standard 2. I always miss this thing. Other monitoring maybe in specific conditions, if you are suspecting any specific thing, that will be additional. But otherwise, usually you are not doing any invasive monitoring unless it is indicated because of some reason. In that case, you can do this arterial line or whatever. Okay, but usually this is the monitoring which you are nerve monitoring for recurrent laryngeal nerve is being done. Okay, usually. So this is one thing. Then the same other things, that maybe this patient needing HDU post-operatively. What will be the analgesia plan? Okay, what will be in addition to like the normal any medication which you are using in any other patient, the specific thing which you can use is the superficial cervical plexus block. Okay, so you can do this. Then like similarly, the same concern will be at the extubation. Okay, an important question which is being frequently asked is airway obstruction. Okay, post thyroidectomy. Okay, so this is a frequently asked question. You have to rule out whether it is because of anesthesia, or because of obstruction, or because of hematoma. Usually these are the causes, and or because of tracheomalacia. Okay, and least like delayed, it can be because of some involvement of other things, but usually immediate post-operative period, it is either anesthesia, either there is some obstruction, there is hematoma, or there is tracheomalacia, which is actually it is also obstruction, but it's specifically tracheomalacia. And then they ask some words about parathyroid. Okay, because thyroid is like parathyroid is nearby. So sometimes if they are not able to identify it, there will be if they have especially total thyroidectomy, in which they are removing all the lobes, there will be more chances. Usually it occurs after 24 to 48 hours, the signs of hypocalcemia. Okay, so their question may be because of this point. They all ask this question. Even MCQs, they ask these points. Okay, so this is an overview about what are the possible things which are going to be asked. Okay, so any questions up till now? Anyone wants to ask any question up till now? Aiza, I will take you and Jameel. Any other exam candidate or anyone wants to volunteer? Okay. So, Jameel, I will start from you. What will be, or Aiza wants to start? Who wants to start, please? Tell.
Yes, sir.
Anyone?
Okay, Aiza, I will start from you. Like, for example, if we just divide it, if you see a goiter, okay?
Yes, sir.
Your main symptom usually will be goiter, okay? Because goiter
Yes, sir.
can be hypo or or will be hyper, okay?
Yes, sir.
It may be hypo or hyper. So what question would you like to ask?
Sir, I start from the history, and in the history, I ask the patient how long is the goiter present, and
Duration,
how duration, and the first time he or she noticed that swelling, and the
okay?
symptoms associated with that swelling, and signs and
Symptoms,
symptoms. Signs and
symptoms
symptoms are
like
like the
pressure
pressure,
symptoms, okay?
orthopnea, dyspnea, PNG,
Dysphagia, dysphagia,
dysphagia. Yes, sir.
SOB,
Dysphagia.
okay?
Yes, sir.
So this
Yes, sir.
was the duration of swelling
Yes, sir.
and how it progressed, and then the
Yes, sir.
pressure symptom. What else would you ask?
And the associated symptoms. Uh,
This can be there either in hypothyroidism or hyperthyroidism. Am I right? Okay.
yes, sir.
So these things can be there either in hyper or hypo. Now, if you want to differentiate between hyper and hypo,
Yes, sir.
so
Yes, sir.
what are the usual
Sir,
questions?
in hyperthyroidism, patient is like more anxious, or there is a history of weight loss, uh, and the sweating history and heat intolerance, and eye signs when proptosis and exophthalmos in hyperthyroidism. And in
Okay.
hypothyroidism, patient is like more lethargic,
No, just a
insom.
second. Just a
Yes,
second. Because first of all, in the exam, this is a blunder that if
yes,
we are talking about history, you have to
yes,
focus
sir.
on symptoms.
Yes, sir.
Okay. Like, because if they are discussing about the history, you have to, sorry, if you are talking about symptoms, this is related to history. And if you are talking about
Yes.
science, this is related to examination. Okay. So
Okay.
first of all,
Okay.
focus specifically on history. So what question you talked about sleep pattern? Okay.
Sleep
You
pattern.
talked
Yes,
about,
sir.
you talk about what
Eating
else?
habits. Sir,
Eating
eating habits
habits, weight,
and weight and lethargy or hyperactiveness.
females. In females, it will be related to menstrual cycle.
Menstrual history. Yes, sir.
Okay. What else?
Uh, sir, swallowing history.
Okay. So that will be
Like,
pressure effects. Okay. Any
yes, sir.
any other question which you can ask to differentiate
Palpitation, yeah, about the
palpitation,
palpitation, about the
Palpitation.
diarrhea or constipation, we can ask from the
diarrhea,
patient.
diarrhea,
Yeah.
constipation?
And
What else?
tremors in the hand, we can ask
Tremors.
how is there is.
Okay. What else?
Sir,
Okay. Okay. So in that, by that history, you will be able to differentiate between hyper or hypo. Okay. Though,
yes, sir.
like, you just think about it, there are some effects on the brain, there are some effects on the heart, there are some effects on the generalized body function. Okay. So that will be eating, sleeping. So because it's matter of fuel, if your fuel is hyperactive, you are burning. Simple words. If your fuel is decreased, your activity is reduced. So you are in hypo mode. There is swelling, and there is sleep disturbance in if it is in hypothyroidism, and it is the other side, like if it is hypo, and if it is like, for example, if it is hyperthyroid, there may be insomnia, and if it is hypothyroidism, maybe it is increased somnolence. Okay. So this is how you will be focusing. Then what about the signs? In examination, what you can find?
The tremors and eye
Okay.
signs.
You know, just a second. If you if you somebody asks you about like this, so I think first you should be always be telling about the vitals.
Okay,
Okay,
okay. So, yes, sir.
because this will,
Vitals.
in that way you will not miss it. So
Yes.
it is not applicable everywhere, but it is better if you say by blood pressure, heart rate, even
And BMI.
consciousness, okay, temperature, respiratory rate. If you comment about it and then go forward, okay. So blood
Sir,
pressure may
should
be
we include BMI in vitals? Like
BMI.
weight?
Yeah, this is
Is
general
it?
thing. BMI, okay.
Yes, sir.
And then this one uh, okay, BMI, there will be some information from BMI as well, that
Yes,
usually
Yeah.
sir.
weight loss
And
in
there is
height.
Weight
a
loss and weight.
other approach which how I learned is from head to toe. It's starting from the
Yes.
head. You know, with the signs there is thin hair in hyperthyroidism.
Hmm.
Patients, if you touch on palpation, patients are sweating, thick, and sweating and wet. And if you come to the then eyesight, they will say the exophthalmos delay of eye close, retraction of the upper lid, and then you can come down, you know, on the neck. If you have see, then you are checked by palpation about the compression of the airway. If you come down, then the heart, in heart there is tachycardia. Might be you can find arrhythmia. Mostly they have some atrial fibrillation, and
Okay.
the hypohypertension depends upon the control of the thyroid.
In
And patients,
hypothyroidism, usually this is it. Hypertension can be there in both of them, but it is
both
more
of them
common
is
But
in
more in
more common
hypo.
hypotension.
hypothyroidism. Okay, then
In
what
Yes.
else?
hypothyroidism or hypertension, yeah. And if you
Heart failure,
then come
signs
heart
of heart
failure,
failure. Okay,
yes,
what
sir.
else? You are, like
Going
you
to
have told
abdomen,
about airway. Okay, you thin hair was not a good answer. Exclude thin hair. Try to be, your approach is correct, that go from head to toe, but try to tell the more important things first. Okay, so airway is the most important thing. Then
there we,
tremors.
yes, we can find out the signs of compression like inferior vena cava compression, maybe
Yes,
sinus, yeah.
yes,
And
retrosternal,
we can find, yeah,
retrosternal
retrosternal
extension.
growth extension. Then we can find the compression. Due to this compression might be there is facial sinus and engorgement of the upper limb veins, and patients have orthopnea, especially on supine position, get relieved on lateral and sitting position.
Okay.
And about lungs most of the times, you know, they're not involved. If I will check, there is, I think, no direct relation with hyperthyroidism. Only patient if hyperthyroidism, mostly they have tachypneic, and to wash out the CO2 due to production of
Uh,
more CO2.
in hypothyroidism, there is association with, okay, obstructive sleep apnea
Okay, sir.
Yeah,
cause of opacity
and yeah,
and
and we also
hypohypertension.
can rule out the hoarseness or stridor due to involvement of the recurrent laryngeal nerve, and
Yes.
also there is hoarseness due to compression of the
Oh,
retrosternal
okay.
growth,
This
also
was
there is edema.
this thing we missed in when we are talking about the pressure symptom. We have to say about
Yes,
voice change. Okay. So this is what I missed actually. So hoarseness, dysphagia. Okay. And we have almost discussed all of them. What about the reflexes?
Yes, sir. It's delay in hypo and more in
Okay.
hyperthyroidism.
And there is one edema. If you just try to just figure out, people try to read separately hypo and hyperthyroidism. And actually, the better way is to keep on comparing. It will be easier for you. No, you will not miss anything. Edema, there is one edema. Edema can be there anywhere, but there is one pretibial mixed edema which occurs in hyperthyroidism.
And retrobulbar edema also in case of grave disease also.
Yes. Okay. This is a separate. We will just go into the details about it. I'm just trying to take you people step by step. I hope it's nice way. If anyone any comments, please let me know. Okay. Okay. So now we have almost covered the main symptoms, the main signs and then investigation. So how will you interpret the investigations? TSH, T3, T4. Okay. If it is low, hyper. Okay. If it is high, hypo. Okay.
Yes, sir.
And in among the T3, T4, which is more important?
T3.
T4.
Which is the active one?
It's more active. It's more
Which
active
one?
than T3.
So T3
Okay.
is more active.
Okay, so
Yes.
we do free T3. Okay. What else among the investigations we do? We
The
do
routine,
CBC.
whole blood count.
Remember one thing,
Yes.
there is no word of routine. Okay.
Okay.
This is
Okay, sir.
irritating answer to the examiner. There is no word of routine investigations. Maybe some examiner will not mind it, but some examiner can mind it. So just try
Okay,
to
sir.
be specific.
Or
CBC to C,
baseline. They also don't like the
baseline
word
or
baseline.
routine. There is no baseline or routine.
Yes.
Okay. Anemia. There is neutropenia. Okay. Especially if patient is taking carbimazole. What else? There are chances of infection, so infective markers can be there. ESR can be raised. What else? Is there any problem in the electrolytes?
Yes, due to sweating, there is also problems of sodium, potassium, and
And calcium.
calcium. Yes, also.
And in the patient is hypertensive, so all the hypertensive medications create problem with the electrolytes. Okay. Now
Yes, sir.
ECG. ECG. What?
Arrhythmias.
Similarly, I'm just trying to give you an idea, so it will be easier for you to understand. But I'm telling you the concept. Maybe I'm not uh, giving you like a gramming of the words. I'm giving you the concept, then it will be easier for you to understand. Okay. So what can be the findings in ECG? Atrial fibrillation is one of them. Then
Rate high. Sinus
both.
tachycardia.
Yes, like it can be sinus arrhythmia, both in the sign of tachy or brady, in either
Tachyal.
of them.
Yes, sir.
Atrial fibrillation, then signs of LVH. Okay, it is a prolonged hypertension. Then it is related to hypertension. Okay, what else? Signs of LVH. What else? Like any arrhythmias can occur. Usually.
Excuse me, I didn't understand the difference of how do we differentiate the edema, so the hypo and hyperthyroidism, please. Thank you.
I don't understand your question. Can you repeat it? That you want to know edema between hyperthyroidism and hypothyroidism. Am I right?
Yes, thank you.
Yes, as we discussed that the edema which is occurring in hyperthyroidism in mainly sometimes because of the antibodies. Am I right, Jamil?
Yes, sir. In hyperthyroidism, there is a specific area where there is edema. It is retrobulbar and
Retrobulbar or
anterior side of the tibia
tibia.
and on the fingers. Only 3 places. But in hypothyroidism, there is generalized edema.
Generalized edema, facial edema,
Facial
edema in the
areas,
feet.
the
Okay.
whole body. Yes.
Thank you.
Okay.
Thank you very much.
Okay. So, like some findings in the ECG, because in the exam they are asking you the case, they are not asking you tidbits. Okay. So, what about, would you like to do echo? When will you do echo in these patients?
If patient came with arrhythmia and we don't know since how long there is
No,
arrhythmia, then we have to rule
especially
out
AF.
the
Okay.
clot, atrial fibrillation. Yes, then
Especially
rule
AF.
out.
If there is AF, you will do echo. Then if there is hypertension with end organ damage, okay, if there is some signs of heart failure, or there is angina, okay, or there is associated diabetes, like clinical risk factor, you will decide
Cardiomyopathy, yes. Also,
according to the
sometimes in
clinical.
extreme stage, both in hypo and hyper, there is cardiomyopathy. Then we
Yes,
also have to rule
cardiomyopathy.
out. Then we
Like,
get edema coma.
actually the symptoms which
Yes,
you
sir.
will be finding on which you will be focusing will be usually heart failure. Okay, heart failure or angina. So then you will be probing it further. If there is decreased physical activity, okay, then you will be going towards the you have to do some like one invasive investigations. Okay. So what else? So thyroid scan, I am not very good about it, but usually it is the diseased area will be taking more dye or decreased dye. Am I right?
Yeah, and also they just rule out the compression of the surrounding area. Sometimes the patient came with the carotid brow, and then they also rule out the compression of the carotid artery by the lateral lobes of thyroid, and they
Carotid
also
artery,
just do the
Jamil, or the
yes, sir,
compression of the
carotid
airway.
artery. Yes, yes, compression of the they do the Doppler
Just a second.
and
Just a second. Just a second. You are too fast. Thyroid scan. I'm asking first of all about thyroid scan. Thyroid scan, usually the concept is that if there is hyperfunction, there will be increased uptake of dye. Am I right? And if there
actually,
is
sir, there is two types of thyroid scan. If you are telling about the isotope scans, then they rule out the cold and warm nodules. It's by the
okay,
isotopes, and there is the ultrasound thyroid scan. They just rule out about the lateral lobes, compression of the thyroid, compression of
no,
the
no, that
carotid
is
gland.
yes, that is ultrasound. Ultrasound is
Yeah,
separate, and I'm talking about thyroid
yes,
scan. Okay, so thyroid scan
yeah. You
is radioisotope. Okay,
nuclear study means yeah.
nuclear study. Okay,
Okay.
so what else? Any other investigations? CT scan.
Where's
Okay.
chest X-ray?
Yes, chest
Chest
X-ray. What will
chest
you
inlet.
find? What you can find in chest X-ray?
Sir, to assess the size of goiter, detect any tracheal compression, deviation.
Yes. Okay, and any signs of heart failure as well.
Yes, sir.
Yeah.
So,
And AP and lateral both. I just want to add in AP we can find out the deviation of the trachea, and in lateral we can find out the rule out the compression. You know,
Thoracic
compression
of
as
inlet
well.
view, we can check in lateral. No?
Also lateral extension. This one, the retrosternal extension. But actually, nowadays they are focusing more on CT scan. Okay. So what else? Naze endoscopy. What is the indication for naze endoscopy, and what finding when can you get?
if is there any hoarseness or stridor, change of voice, and
The vocal
then
No,
we
no.
cord
can.
function actually to
Just a second.
document the
What finding?
vocal cord.
Jamil, this is, you are telling the reason. Yes, Aiza, what will be the findings? What can be the
The vocal
findings?
cord function, we can check the
Vocal,
vocal cord function.
vocal cord function. This is one thing. What else? Airway distortion.
Yes, sir.
Okay. And actually, this vocal cord function is for medical legal as well. Okay. Okay. This is for medical legal as well as for post-op possible complication. Okay. So we discussed about the common investigation and their interpretation. In CT scan, you can find the extension. The chest X-ray, you can find some signs of heart failure, tracheal deviation, or retrosternal extension. AP lateral this X-ray neck, okay, in which you can find the tracheal compression, or so that this is how you will be analyzing the patient. So at the end, you will be seeing that patient should be clinically as well as biochemically. Patient should be euthyroid. Okay.
So we can also check the flow volume loops.
Of course. You see, that's what because
Yeah.
I'm not making it a prepared lecture. I'm just
Yes,
doing
sir.
extempore. So please just feel free, and we are doing an interactive. So flow volume loops is very important. Okay. Flow volume loops will tell you compression.
Yes, sir. Fixed upper way obstruction.
Okay, usually it is fixed, but if it is for example, if it is retrosternal, it can be intrathoracic. Okay. Sorry, no, I'm use the wrong word. Extrathoracic. In retrosternal, it will be extrathoracic, which will be showing
No,
in the.
sir. You are right. I think extrathoracic is not retrosternum. Retrosternum is intrathoracic. It's in the thoracic cavity already, and extrathoracic in the neck, and it
No,
might be.
just a second. We say that the problem in flow volume loops in inspiration, it is because of extrathoracic. Am I right? And in expiration, it is because of intrathoracic. So here,
Yes,
this
opposite.
retrosternal, we say as intrathoracic or extrathoracic. I'm confused myself.
Sir, I just want to explain that there is might be intrathoracic, or it be variable intrathoracic, variable extrathoracic, and fixed obstruction. If it's extrathoracic, means it's outside the thoracic cavity, it will be okay in inspiration. Lobe will be like a arc, and
Okay, I
yeah,
understand.
and
It is intrathoracic. Actually, I was telling that intrathoracic and
variable.
it will be shown in the expiratory time. Okay, it will be in the expiratory. It will be shown in the expiratory phase. The intrathoracic obstruction will be shown in the expiratory phase. That's what I was telling. That's I just use the wrong word. Anyways, so up till
Yes,
now.
because in intrathoracic, there will, when in inspiration, it will pull by the negative pressure in the thoracic. Inspiration in inspiration will be okay. When there will be expiration, it will be compression of the trachea, and expiratory loop, it will be disorganized, means,
Yes, and then
or
fixed
decreased.
One thing
as
more,
Isa and as
I
Pfizer
want,
Isa told, the fixed one will be there. Okay.
and in also in the loop you can see like on the result like that there will be less total lung capacity and the residual volume.
Yes. Okay. So any other investigation we missed? Because in the long case, they will be asking you in a similar way. They will be asking you there. You will be taking the history, as we discussed before, the whole of the history package. If you have not seen, you can see our previous discussion which we did for general approach. So you will find the same things here. You will focusing. Then you will be focusing on the history related to thyroid, and then you will make up a mind. Then you will do the investigation, and at the end of the day you will be finding it either it is euthyroid or hyperthyroid or hypothyroid. Okay, so then you will be planning out the whole of the main. Okay, now if we just discuss about the airway management in thyroid. Okay. So what if you have a large thyroid? Okay. So how will you induce? Isa, please tell. Or anyone else? Yes.
Sir, in large thyroid, after the complete history and investigation, I'll go with the sir. There are two options in which we can perform a thyroid surgery. Either we will go with the regional, or either we will go with the GA. In regional, we can perform the superficial cervical plexus block, in which we can perform the
No.
thyroid surgery.
Just a second. We cannot perform superficial thyroid surgery wholly solely in superficial cervical plexus block. It's not possible.
Yes.
Sir, with mild, sir, with the pre-medication.
No,
No.
you are
With this,
confusing
G.
it. Just as Jamil, let me talk. You are confusing it with carotid endarterectomy.
Sir, I'm working in DHQ Jhang, and my it's consultant. Sir,
Remember
he's your
one thing.
senior too. Dr. Asif,
Remember
we
one thing.
perform.
Remember
Sir.
one thing. Remember one
Yes,
thing,
sir.
Isa. You cannot
Yes, sir.
code this thing in exam.
Okay, sir. Okay.
This is what you everyone will be understanding. This is haram. If
Okay,
you
sir.
say one of our candidate, he used to say, get ready with 15,500 rupees. If you give this answer, be ready for another
Okay.
attempt. Okay.
Okay, sir.
Never
Okay, sir.
say this thing in exam. Never ever.
Okay.
That if you have any doubt that there will be problem, you will go for a WAC fiber optic. Okay. This should be your first answer. Forget about practical. Okay. I have never done awake fiber optic in thyroid patient. We always succeed. But actually in the exam, you have to say, if you have any doubt, you will go for awake fiber optic. The second
Okay,
technique
sir.
will be inhalational induction
Inhalational induction. Yes, sir.
with
Good
preservation
pre-oxygenation. Yes, sir.
of spontaneous ventilation.
Okay.
Preservation of spontaneous ventilation. Then check laryngoscopy. If you are able to visualize the cord, then you can give muscle relaxant.
Okay, sir.
Or even this is, some people will say this is also dangerous. So when you are, then you can give some sleeping dose of propofol. You can give some lidocaine, and then you can give suxamethonium. Okay, at that time, when you are able to, there will be few questions. You are able to ventilate. So the patient's spontaneous ventilation was like, I will just write it again. This you did it inhalational induction. Okay, you do inhalational with spontaneous ventilation. Then you do check laryngoscopy. Okay, you visualize the cords. Then you can give short acting muscle relaxant suxamethonium. Because, for example, after giving muscle relaxation, if you are not able to, because maybe you are patient, when the patient is breathing, there is then muscle, we have not given the muscle relaxant, patient is able to maintain the tone of the airway. But as soon as you give muscle relaxant, you can bob down. Okay. So long acting muscle relaxant is not advisable to be used in such patients unless you are able to visualize. You can give now at this time, you can give suxamethonium, you can give other medication, rocuronium or atracurium as well. So this is two techniques which you can tell in exam. Okay. Yes. Now, Jamil, you want to comment, or anyone?
Yes, sir, you are right. Just first off, as the Dr. Isaac told that, on the basis of history and examination, then, we can add that I will prepare all difficult every trolley, including the rigid bronchoscope or video assisted meningioscopy also. And it depends upon the obstruction of the airway difficulty, the airways on the CT scan reports, if it's retrosternal compression, and I will rule out the size of and the area of the compression and internal diameter of the trachea that there is maximum compression. Then I will select my endotracheal tube according to that compression. Then we can go, there is two approaches. It is definitely largely very large thyroid. Then we can go for awake fiber optic. Then we will mention all the method how we go for awake fiber optics. Other option is sleep fiber optic. Then we can go sleep with the inhalational agents, taking care that the patient will not go to our patient maintain the spontaneous ventilation. And yeah, this is the thing, yeah, you already told that, we will first assess by the laryngoscopy, and then we can go for modified rapid sequence induction by coronium, or if it's not available sugammadex, then we go for succinylcholine.
Okay, so this is important because whole of your exam viva will be on this point. Okay, so at the same time, maybe it is a little in a disorganized way, but at the same time, because we are talking about airway, I will have a detailed discussion on the same which they ask in the after post-operative, like how will you extubate? We intubate the patient, how will you extubate? Yes, long-standing thyroid.
Yes, if there is long-standing thyroid, then I try to extubate the patient awake, and I will blunt the laryngeal reflex by 1.5 milligram of lignocaine or short-acting beta blocker like esmolol. And first, I will check by the patency of the airway by deflating the endotracheal tube, and I will check leak test.
Leak test.
And if
Okay.
there is decrease
What
in
is the significance? What is the significance of this leak test? If anyone don't understand, please feel free to raise the hand. Okay. If anyone
I will check the inspiratory tidal volume and expiratory tidal volume. If there is there should be decrease in expiratory tidal volumes by the monitor if there is leak, and if there is no decrease more than 10% of the
yeah, this is also, and there is you can listen to the visible leak.
Yes, sound. You can even put the stethoscope on the neck, and you can find some sounds of air
Even
leak.
without stethoscope, you will find the sounds. If usually
if definitely if there is a big leak, can even is
you
audible.
will increase the airway pressure a little bit by closing the apial valve, and you will see that whether there is leak or not. If there is leak, it is a good sign. If there is leak, if there is no leak, what will you do?
Then I suspect that it might be there is tracheomalacia. And the other option, if I have available fiber optic, then I go through the endotracheal tube to assess the upper airway, means the trachea. Is there any compression? After that, there is two things. First is extubation over the fiber optic cord. I will gradually remove the endotracheal tube, keeping the fiber optic cord.
You will put the fiber optic through the endotracheal tube, and you will gradually withdraw.
Yes, gradually withdraw, and then we'll assess if there is any risk and there is tracheomalacia, a river collapse, then I will not extubate the patient. I will again push in the endotracheal tube. Other option is if there is not available of fiber optic, then I have to prepare beside my this medical hook entry or rigid bronchoscope. I will extubate the patient, do the laryngoscopy, assess the vocal cords, and if there is obstruction of the of the airway due to the tracheomalacia, I will try to intubate, but it has some bigger resistance. Then I go for that PUG, or I will go for the rigid bronchoscope to intubate the patient.
And similarly, if you
I-
extubate the patient and there was obstruction, then the ENT people should be on board with rigid bronchoscope. Or if, for example, there is another way, is to make the patient lateral. Okay.
Yes, yeah.
If you will make the patient little lateral, this
It
obstruction will
will
be
help.
decreased.
Yes, it will decrease the compression on the trachea.
Sir,
Okay.
besides leak test and fiber optic, we can also do the ultrasound of the neck and see the
Ultrasound.
air around the cuff.
Ultrasound of the neck. Okay, this is also a new development. You are absolutely right. You can assess the airway via ultrasound as well. Okay, what else? Jamil, you are very good in this topic. I am very bad in this topic. Now we will discuss about the similar at same time injury. Okay,
Yes.
so one is unilateral, one is bilateral. Okay, one is complete and other is incomplete.
Incomplete, yes.
Okay, and acute and chronic. So as if you can just explain. Unilateral, complete, there will be hoarseness.
Yeah, if unilateral and complete
Either
will be the
complete or
hoarseness
incomplete.
also.
In both
Incomplete,
cases,
both will be hoarseness
there
only.
will be hoarseness. Okay, and
Yes.
what?
Assalamualaikum. Excuse me, sir, I have a question.
Yes,
Regarding extubation, I just want to ask, we can mention about check laryngoscopy for looking for the vocal cord mobility or not?
yes. I missed it. Thank you. Thanks for reminding. This is absolutely
And
that we have to visualize the vocal cords.
and then we can go for it will be easy to differentiate either it is due to the laryngeal nerve damage or due to the laryngomalacia. So what
Tracheomalacia.
first of all we will say, sorry, tracheomalacia. So first of all we will say that check laryngoscopy for vocal cord mobility, and then we will go for other steps.
Yes, you are right. You are right.
The
Okay.
second,
Leak
my
test,
question is,
and laryngoscopy. Laryngoscopy and leak
someone
test.
mentioned about the leak test that we will check the leak test by putting the stent on neck. So what is the significance of putting the stethoscope on the neck?
If there is
I
leak,
didn't.
if there is leak,
We
you
will put the
actually
stent well on the neck or at the oral cavity. I have a confusion in this.
I tell you something. Actually, practically speaking, I will ask you in another way. When you put a tube of smaller size or uncuffed tube, you are listening to the leak. So you don't put any stethoscope, you are listening it. Okay? You just bring
Yes,
your
sir. That is obviously audible without
so
any.
that's what I'm saying, that you can put the because of course you cannot put it on the oral cavity. If you want to notice that if there is leak, you can put it on the neck.
Sir,
Okay.
there will be air movement through the ETT or
There will
outside the
be
ETT. So would
extra
Beside the
any difference?
beside the ETT. Yes.
Beside the ETT, we will hear about the air leak, na? But
Yes.
my
Yes.
point is that air is moving through the ETT, even through the ETT. So there
you
will be
know,
any differentiation, or that is not heard through the stats.
yes,
My
I tell you something. These things you only tell when you have told the other things. Okay. Because in the exam there is not that much time to tell everything. Okay. The more important
No,
thing is that
actually, she just wants to clear the concepts.
no,
Through
you
ETT, Dr. Saiba, there is a laminar flow. There is less likely if there is flow through the ETT, it will give some sounds. And the area beside the ETT, it's narrow and there is some tissues. And when there is flow through this area beside the ETT and the tissues, there will be turbulent flow. It will vibrate the connect soft tissues of the trachea, and it will give the sounds. This is the concepts. And if there is big sound leak, there will be automatically the sound that you can hear by from 3 to 4 foot, even outside, understanding on the head side. If there is small leak and you cannot listen any audible sounds, or you cannot differentiate, then you can put the stethoscope, especially in children. Not in the thyroid, but in children sometimes there is some upper airway inflammation, and there is some leak test. Then there will be definitely very small tidal volume, very good, give the minute ventilation at very low rate, and there is small leak. There it helps the stethoscope. Otherwise, in routine, we cannot, we don't put the stethoscope on the neck. But sometimes, you just, if there is, you cannot listen loudly, then you can listen by this stethoscope. Putting lateral side of the neck, you just
Okay.
put and you will listen the sounds.
Okay, Aiza, who doctor, you
Yes, sir.
understand? Your name is not visible.
Ji sir, thank you so much. This was my confusion, which
No
is now
problem.
clear.
No
That
problem. Actually, what
and so
I
second, can you
yes,
Ji?
yes, please.
Sir, can you please repeat about the fiber optic procedure during extubation? But what I understand
Actually, listen,
is
the
to
thing is that
be
don't overdo it. This question, if they will be asking you, this will be a very small question. How will you extubate? Okay. So answer will be that at the time of extubation, you will make sure there is no nerve damage or there is no tracheomalacia. This is the purpose. Whatever you are doing technique, whatever technique you are using, the purpose is this thing. Yes, you should be anticipating that if you extubate and there is obstruction, what will you do? So the answer is that you will put the rigid bronchoscope or you will put in the lateral position. This is if you extubated. Before extubation, what you can do
Okay.
as
Yes,
as you
excuse me,
as
sir, if you don't mind,
just a second.
I can explain the procedure, how we can do the wake fiber
Jamil,
optic if there is
just
time.
give me a chance, please. Just let me finish,
Okay,
please.
sir. Okay.
Okay, so this is after we extubated and you face the problem. Before extubation, the things which you can do is that you can do the check laryngoscopy as you told, and you see the visible movement of the cord. This is one thing. Then you can do the leak test. If you find some leak, then it is a good sign. Then another thing is if you have a doubt, you will pass this one fiber optic from the side of the endotracheal tube to see the exam if you ever whether you are able to pass through the that area. If it is not and there is not much edema, or you can visualize what's the situation. Okay, if there is any problem, you will be able to judge it. Then the next step, as Jamil told, that you will pass the endotracheal tube through, sorry, you will pass the fiber optic through the endotracheal tube and gradually withdraw with fiber optic, and you will be looking at the collapse. If the area distal to the endotracheal tube, when you pull it out, there is collapse, you will not extubate. Okay, you will just stop and you will keep the patient intubated, because if you extubate the patient, you will have problem. I understand.
yes, sir. Thank you. And last question, if there is bilateral vocal cord palsy, so we
We will
will
just
not
discuss. Just
extubate the
give me
patient.
just a second, Jamil. Now you were
No,
telling the same thing or anything I have
Yes,
missed?
sir. Yes, sir. And the one thing, just we want to add that we keep the patient deep with inhalational. Patient will
Yes.
be spontaneous breathing when we check the tracheomalacia, but we will still not switch off or wash out the inhalational agents. Okay. This is the other thing I just want to add. We keep the patient deep when we check the tracheomalacia. We put the endotracheal through the endotracheal tube, this awake fiber
But
optic cord.
once we confirmed it, we have to
Yes,
make the patient awake, and we will not extubate
yes, yes,
before the
yes,
patient
yes.
get awake. Okay.
Yes, when there is
Now,
no tracheomalacia, we withdraw the awake fiber optic cord, and then we switch off all the inhalation agent. Then we awake the patient. After that, then we extubate the patient later.
yes. Okay, so now we will discuss this recurrent laryngeal nerve, what we were saying. In unilateral, there is hoarseness. Okay. There in bilateral, what will happen?
Bilateral, sir, there is acute, there is will be, yeah, acute and chronic. But our concern is interpretive as acute. Then there will be stridor because
Stridor.
it will be both in the mid side.
Okay. So what about complete and incomplete? Is there any difference in complete?
Actually, yeah, there is actually if we talk about the complete and incomplete, and then we have to understand about their abduction and adduction effect of the vocal cords or function of the vocal cords. Vocal cords are both have adduction and abduction. Adduction, when they will be closed, it's during the inspiration, during the speech. When we speech, they are in the midline, they are adducted, they are completely closed, and with small opening there is air leak and we can speak. But inspiration, there is abduction. They just open the vocal cord, they go away from each other, and in the adduction function is more sensitive than abduction. If in incomplete injury, the abduction function it will remain, but adduction will be suffered. Means again, if incomplete injury, there will be also stridor in acute and incomplete injury. That's why incomplete injury is more dangerous than complete injury. In complete injury, it more will be paralyzed and vocal cord will be in abducted form. Means there will be little bit opening. There is risk of aspiration. There will be hoarseness. But in incomplete injury and in acute, the vocal cord will be in midline. There will be stridor and dyspnea.
Yes, I hope you understand. This is a very
Yes.
critical concept. And the one thing I will add that if there is a superior laryngeal nerve injury, then this is the muscle for cricothyroid, the external branch. Okay. So this is the tensor. So what will happen in it? Yes,
Aphonia.
Jim.
No,
Aphonia?
no,
No. Again,
no. There
there
will
will
be
The
be
hoarseness
hoarseness.
hoarseness,
because it's
the
tensor.
hoarseness if bilateral.
Sorry.
So there is hoarseness if bilateral, and if there is unilateral, then minimal symptoms.
Minimum symptom.
Yeah,
That's it.
minimum symptom because it's just tensor.
Tensor.
Actually, it's used for the pitch of the sound. It's if they are in means tense position, then we can speak loudly and our pitch will be also okay. In case of their damage, it will be like hanging and loose. And unilateral, it's minimum effect. But if the bilateral, the paralysis, there is maximum will be hoarseness.
Okay. So this is an important concept. Now we will just go through some of the articles and we'll see what we have done up till now. Uh, some of the causes of hyperthyroidism. One of
Sir,
them
in
is,
article, sir, in article they also mentioned the regional technique. Now that is a superficial
remember
cervical.
one thing, remember one thing.
Yes, sir.
That's what I
Yes,
try to say, that it
yes, sir.
is for analgesia, not for anesthesia.
Okay,
Okay.
okay, sir.
This is only for analgesia. Analgesia, I told. Superficial
Okay, sir.
cervical plexus and deep cervical plexus
We
block.
also give the analgesia, but also postoperative analgesia, even
Okay.
intraoperative. Only one injection. It's on the middle left side of the uh, sternocleidomastoid muscles, and it covers the four branches. But remember, it's only cover the skin. But if they go deeply, especially on the lateral lobes, it will not cover. If you can give if the deep cervical and with local infiltration, then might be you will cover. But it's less likely, that they will impress by this your technique. If you give the both superficial and lateral deep cervical block with the infiltration by the surgeon, and it's not a good technique, it's not still recommended.
So, some of the causes for thyroid surgery, malignancy, goiter, hyper or hypothyroid. Okay. So, Graves' disease, it is because of autoimmune condition. Okay. And there is autoimmune antibodies. mimicking TSH. So the thyroid, thyroid hormone synthesis is uncontrolled. Okay. So as we discussed before, there are eye signs, there are pretibial mixed edema. It can be associated with other autoimmune disease like myasthenia gravis and some carcinoid, or I'm not sure what autoimmune diseases, but it is associated with autoimmune disease. Okay. Then thyroid secreting adenomas often presenting as a solitary nodule. Okay. Then toxic multinodal
Even the diabetes also, in hyperthyroidism, less
yes.
because they have low threshold for the glucose, because of the anti-insulin hormones also increase due to this thyroid hormones is anti-insulin hormone, and in hyperthyroidism there is some resistance of the insulin, there is increased level of blood glucose, they are more prone for diabetes also.
Yes, okay. So exogenous iodine, amiodarone. They don't forget this medication. It can cause hyperthyroidism. And all thyroiditis usually causes hyperthyroidism except Hashimoto's. Hashimoto's thyroiditis cause hypothyroidism. Okay. And the most common in our part of the world is iodine deficiency. Okay. There is gland hypertrophy and hypothyroid function. Okay. So now I will just the same time I will revise some of the concerns related to malignancy. Okay. So actually, whenever there is malignancy, there is some signs of the local spread. Okay. Local, distant, bone marrow. Okay. And problems related to chemotherapy and radiotherapy. Okay. So local effects will be compression, or especially if it is airway, that will be significant. Distal will be because of liver metastasis or bone. Okay. There will be like pathological fractures, liver dysfunction. Okay. And this lymph nodes will be enlarged. In bone marrow, also because of the chemotherapy. Okay. So there will be anemia, there will be pancytopenia. Okay. There will be liver dysfunction in because of these chemotherapeutic agents. So whenever you are, and then these everyone you will be not forgetting, you will be forgetting is the opioids, because usually cancers are painful, so the patients are on opioids, so there is opioid dependency. Okay. And there is a role of palliative care. Okay. So this is generalized points for any cancer actually. Some of them will have more, some of them will be less. And then chemotherapy related multisystemic effects, in addition to the cell lines and everything, nephrotoxicity, hepatotoxicity. Important thing is cardiac depression. Okay. So whenever patient has received chemotherapy, you have to do echo, because there are chances of patient having some cardiac depression, or they do before starting chemotherapy, they do please whose mic is unmute, please mute the mic. Okay. So then this is also an indication for echo. If you are starting a chemotherapeutic agent, they do sometimes the baseline echo to see any further decompensation if it occurs. Okay. So I just wanted to show you these things. Okay. So malignancy.
Excuse me, sir.
Yes.
Yeah, you told the things in details, and but there is other approach according to our teacher Dr. Salman, that there will be other fourth M will be sometimes 3M. If there is
Mass.
4M, it's metabolic. Like first is mass effect, again
Yes.
medication effect.
I forgot.
Yeah.
I forgot. It is the tumor secretion. Okay.
Yes.
It will be
Then we.
any, like for your the example is pheochromocytoma. Okay. Or this men 1, men 2. These are tumors. Neuroendocrine carcinoid tumors.
Excuse
Okay.
me, sir. Can you just please, sir, can you please tell the
No, sir.
what is
Actually,
meant
I
by
am telling
4M?
about the 4Ms. 4Ms means 4 I told,
Mass
3Ms.
malignancy.
Just a second, please.
Yes.
Just a second. Calm down. Calm down. Calm down. One at a time, please. Otherwise, nobody will be able to listen. Jamil, I understand your point. You are telling that all these mass effects, medication, and the what is the third ma'am? Medication, metabolic. What is the other?
Malignancy.
No,
Malignancy.
no. Jamil, yes, please. What is the third M?
Yes. Like some mass, medication,
Yes.
metabolic, and metastatic.
Yes,
Means
metastatic. Okay.
yes, if in spreading onto other organs in the liver, then it's all effects of the liver derangement.
Yes. So this is what you are saying. This one metabolic is related to the secretions. So carcinoid is also an example. Men is also an example. Pheochromocytoma is also an example of the metabolic or the release of anything like thyroid tumors. They release thyroid hormone. So this is an example of not only mass effect, metastatic effect. This is the effect which is there because of the hormones. Am I right, Jamil? Okay, so now please, who was asking? Now please tell what you are asking. You were asking something? Someone else was asking? Please speak out.
Sir, I just want to know about the 4Ms. And I got it. Yes, sir.
Okay, so this is the 4
Yes, sir.
M's.
Thank you.
Okay. Okay, so anesthetic considerations, we have actually, we will just recap. We have discussed almost everything. I will just have a look if I missed anything. So the symptoms of hyper and hypo, and then size, position, nature, pathological nature, distortions, signs of dysphagia, breathlessness, change in voice, stridor. Okay, so autoimmune associated also autoimmune problems. Then an examination of goiter, like we have discussed, weight loss, the malaise, muscle weakness, heat intolerance, cachexia, palmar erythema. Palmar erythema, I don't know palmar erythema, why it is up to proximal muscle wasting, pretibial myxedema in Graves' disease, irritability, anxiety, okay, tremors, hyperkinesis, hyper movement of the, then palpitation, angina, breathlessness, hypertension, cardiac failure, tachycardia. We have discussed almost everything. Problem with the eating, vomiting, diarrhea, oligomenorrhea, loss of libido, and because of eye signs. Okay. So similarly, the hypothyroid sign, malaise, cold intolerance, myalgia, arthralgia, peaches and cream complexion. You see, some things every day we learn. What is this? Do anyone knows about it? Peaches and cream complexion. What is this? Dr. Humera, please mute your mic. Your mic is disturbing. Have anyone got any idea? I don't know. We will not waste time on it. Must just try to learn it. But please don't use these fancy words unless you are able to explain. Okay. Depression, psychosis, mental slowness, etc., etc., etc.
Sir, it's written like clear, pale skin, clear, smooth, and
Clear,
pale
pale.
skin. That's
Yes,
yes, sir.
This answer is
Pale
only
skin.
expected from a woman. No, men miskin, they cannot answer this question.
Oh, what is the question, sir? There was noise. I could not catch you.
Yes, this is peaches and cream complexion. So she has told that clean and pale complexion. Okay. Okay. So routine blood tests, electrolyte, thyroid function, calcium level, as we discussed, because this we have to track post-operatively to detect hypoparathyroidism. Okay. Chest X-ray to assess the size of goiter, any tracheal compression, lateral X-ray, thoracic inlet. Okay. Then what is considered CT scan, nasendoscopy, flow volume loops. Alhamdulillah, we did not miss anything. So this is another important thing which they will be asking you, the anti-thyroid drugs. What is the mechanism of action? what is their side effects. So you should be just knowing that carbimazole, this is an MCQ as well, which thyroid anti-thyroid drug is a prodrug. So it is converted to methimazole, and it prevents the synthesis of T3 and T4 by blocking oxidation of iodine. Okay. And inhibiting thyroid peroxidase. And it needs around 6 to 8 weeks. And the side effects are agranulocytosis, bone marrow suppression, arthralgia, pruritus. Even if you are knowing 1 or 2, it is enough. The important thing is that in pregnancy, it is not being used. Okay. So it is in the pregnancy, which is you usually use is this one, propylthiouracil. Okay.
Propylthiouracil.
So, and the another difference between carbimazole and propylthiouracil is that it also inhibits the conversion of T4 to T3. Okay, so it prevents the active form. So dosage
Then
in
is it important for us to remember the dose?
Yes, in Pakistani exam system, it is. I will not comment anything. I'm being asked not to complain, but it is a reality. They ask. This is a nonsense question, but they ask.
Sir, they in all the exams, also in European diploma, they ask the dosage.
Dosage?
They are very
No.
concerned about the, yeah.
Really?
Yeah, they are
I'm
really
really
concerned
surprised.
about the dosing.
I'm really surprised because dosage of the anti-thyroid medications is none of our business. It's being used by the endocrinologist and they are titrating it. I don't think so. It should be an important thing for us. Anyways, no comments. Examiners, they are Badsha, they are king, they can ask anything. Okay. So this is another difference between carbimazole and propylthiouracil. And you should be knowing some of the side effects: hepatitis, thrombocytopenia. Okay. Then the Lugol iodine. Actually, Lugol's iodine is to decrease the vascularity. Okay, and it is usually given if you have less time. So you can destroy the vascularity by giving Lugol's iodine. Okay, and propranolol. There another medication which is not written is dexamethasone, which is also given to convert the peripheral conversion. Okay. Similarly, dexamethasone or hydrocortisone, it is actually the steroids which you need to give to prevent the peripheral conversion. And propranolol is also given for the metabolic effects, the sympathetic effects. Okay. So you should be knowing about it. Then optimization, as we told that which will take few enzylysis, and then what else? Anticholinergics if you are planning for fiber optic. Okay, so for fiber optic, you should be giving the nerve blocks for the fiber optic. Usually it is the gargles with lidocaine, nasal plagets. Okay, and then frequent gargles. Then you can do a transtracheal, and usually in place of invasive blocks, spray as you go technique is a better one. Okay, so they do the gargles and then they keep spraying and keep moving forward. This is how they will ask you if you tell that awake fiber optic, you should be knowing how to perform awake fiber optic. Okay, so now another thing is that we are talking up till now about the elective patient for thyroid surgery, but this patient can present for any other surgery like obstruction or any emergency surgery. So so you should be knowing how to answer that thing, because in that case you don't have the time and you are expecting actually thyroid crisis. Okay, understand? So you will be expecting everything, and then if thyroid crisis occur, the approach will be airway, breathing, circulation. You will be immediately call for help, immediately inform the surgeon. You will start the cooling maneuvers. You will irrigate with cold saline, and then you will be using steroids. You will be using we will be putting the NG tube and start oral medications, but actually it will take some time, and actually supportive management. If there is any arrhythmia, you will be treating the arrhythmias, and the general approach. Okay, in some books or somewhere it is written that there is some role of dantrolene as it will inhibit the metabolic pathway. So this is some words about thyroid crisis. Okay, if you were someone was just mentioning this thing, so this is actually not purely for surgery. Okay, if they have mentioned this technique, you see, it can still have a place either as a sole technique or with sedation. But remember one thing, this statement, it is difficult for you to defend in the exam. So don't try to be a hero, try to remain simple. Okay.
Sir, what will be the approach if they ask any emergency surgery like fetal bradycardia for CS with patient with thyroid, hypothyroidism with difficult airway?
So you have to try to go for rapid sequence spinal. What do you think?
Yeah, if
Have
this
you heard
no
about
this fetal brady, then definitely there is no
GA?
time for spinal analysis, GA. And if there is difficult airway also like
Actually,
big
there is a
thyroid.
concept of rapid sequence spinal. Have you heard about it?
No, sir.
They do it in lateral position. They don't do preloading. Okay. And that is uh, uh, one way. They add bicarb. Okay. So by that way, you can enhance and quicken up the effect of spinal. So this is one of the thing which we can say. Otherwise, of course, this will be a tricky. Dr. Humera, your mic is constantly disturbing us. Yes. So this one uh, in emergency situation, of course, you will be going for, what will you do actually? Awake fiber optic? No.
No, difficult risk of that times patients. There is no time for awake fiber option. First repeat bradycardia and also if patient is full stomach, then we will. It's not a good option.
What is the priority in this patient? The mother or the fetus?
Definitely mother.
Mother.
So actually, this is you can say that there is no safe technique for it. One of them I have told, rapid sequence is final. If you are going for GA, then you have to outweigh risk versus benefit. Okay, and in this scenario, if the technique which you can use, actually, I don't have a very good answer for this question, honestly speaking. What will you do if you give muscle relaxant to start with? Rapid sequence induction you cannot do. Okay, so I think you can do some cricoid, because even if you are saying cricoid pressure in this large thyroid, you cannot even do cricoid pressure nicely. So what should be the answer? Inhalational induction with check laryngoscopy. This is one of them. Okay, that's what you can do, because there is always a risk. You can make a ramp position which will decrease the chances of aspiration, and then you will do the pre-oxygenation, and either you will do inhalational induction with the check laryngoscopy, or if you have any doubt, because if you give muscle relaxant with propofol and you are not able to even ventilate, patient will die. Am I right?
Yes, sir.
So actually, in this scenario, awake, you can say that you will counsel the patient that there is no other way. You have to do awake fiber optic. This is one of the thing, because you have to save the life of the patient as well. What about LMA? Would you like to put LMA?
The risk of
LMA,
aspiration is there. Full
respiration.
stop.
Yeah, still there is risk of aspiration, but
Again, I am
if there
saying
is
that you
like
will
a
tell.
pro-seal LMA or there is intubating LMA, you can take the risk, but there is risk of aspiration also.
So there is risk in everything you do. Okay. So you
Mm.
have to outweigh the risk versus benefit. That's what I'm saying, that one of them is, again, I repeat that rapid sequence spinal is one of the technique. Okay. So other thing, whatever you are telling, you say that no technique is safe. So you will decide on the situation there are different options. You can go because there is risk of aspiration in whatever you are doing.
Yes, even modified rapid induction, there is also risk of we will lose the airway, even if
Yes.
there is available oxygomidex, because it's also take time 3 to 4 minutes, and we give the with propofol also. It will patient go will apnea.
So you can say that
So,
I will just make
yeah.
a ramp position. A ramp position, you know about it, rapid airway management position,
Yes,
in
sir.
which you
Yes.
elevate the head. It will increase the FRC. It will increase the chances of you to, even if, for example, if you want to ventilate, if there is any problem, then the risk of aspiration is slightly reduced, because the pressure should be increased more to counteract the movement against gravity. Because if you have make a little head side or this patient a little up in ramp position, then there will be less chances of aspiration. Okay, so this is all you can do, but there is no,
And
don't
also,
say
I will
this
give
is the
the
best answer.
antacid, yeah, antacid
Yes,
uh,
acid prophylaxis.
0.3 mole. Yes,
Yes,
acid
acid
prophylaxis also.
prophylaxis will you do? Again,
Yeah.
acid prophylaxis also has problem, because acid prophylaxis can
Increase
increase
the
the gastric
volume,
volume.
but there will be decrease the pH, but pH is more important than the volume, more than 25 ml, because if even it's less than 25 ml and pH is very strong acidic, it's more lethal than the volume also.
Yes, you see, they have written here there is no safe technique actually. Okay, so this is how you have to manage. Okay, so why they do this Valsalva maneuver in during the
Yeah,
surgery?
during the surgery they
Sir,
do
to
well
check for
sulfur.
hemostasis.
Just Jamil, let her talk,
Sorry.
please. Let her talk. Let her talk, please. Yes, Isa. Why we do this Valsalva maneuver?
Sir, to check for the hemostasis.
Only hemostasis or something else?
Um,
Because actually, if they have ruptured the pleura, there will be leak. Okay.
okay. Okay.
So this is not only for hemostasis. That's why remember one thing. Don't worship any source, because no source is perfect. Okay. Articles are very good. They give you a very good insight. But again, I will say that you have to be wise what to pick and what not to pick. Okay. And what to add, because hemostasis is one of them. The other thing is if there is any tear in pleura, this will be visible. Yes, Jamil, what you were saying? Anything else than Isa told?
Yeah, the both things, there is increase of intrathoracic pressure. It is engorgement of the cervical veins, and they will check the hemostasis first. Second, then definitely if they also manipulate the trachea, and if they damage other pleura or other trachea, if there is any leak, then can also find out with Valsalva maneuver.
Yes. Okay. So at the emergence, which we as we discussed, there are different techniques. There's you see fully reverse, patient sat up, endotracheal cuff deflated to ensure leak. Okay. In our so we extubate our patients awake. It is important to minimize airway manipulation, and as they told before, you will be doing the blunting the stress response with the lidocaine and other things, and also to prevent the edema. Okay. If there is a stridor or any airway obstruction, you can use also the racemic epinephrine. It's not written here, but racemic epinephrine, whenever there is edema, you can use this racemic epinephrine. Okay. So as we discussed, the question they ask in almost every patient, what happens if you have airway obstruction post-operatively? Okay. So this is the post-operative bleeding, and you will immediately call for help, immediately call the surgical resident. You should have a clip of this one. If there is this one suture opener, you should have. Okay. But actually this will be the responsibility of the surgeon. But in immediate, if you are seeing that there is obstruction, patient is going down, you will put prop up, oxygen, airway breathing circulation, and then if there is visible edema or swelling, you can remove the surgical clips. Okay. So then reintubation. Laryngeal edema, we have discussed humidified oxygen, steroids, also the racemic epinephrine. It's not written here. Recurrent laryngeal nerve, we have discussed already. Okay. Traction, entrapment, unilateral will present with disparity, difficulty, hoarseness, or difficulty in phonation, while bilateral palsy will result in complete adduction of the cords and stridor. Okay. Bilateral recurrent laryngeal palsy requires immediate reintubation, and the patient may subsequently need a tracheostomy. Okay. So hypocalcemia, it usually occurs after 48 to 72 hours, but it can occur even before that. There will be Jovistic sign and Trousseau sign, carpopedal spasm, and because of hypocalcemia and QT prolongation. Okay, so you have to give calcium gluconate or calcium chloride. Okay, trichomalacia, if there is prolonged thyroid, there is chances of trichomalacia. Okay, and as we discussed before, the same thing. We will be doing a leak test, and we will add the technique by fiber optic, use of fiber optic, and you should have a rigid bronchoscope bedside with you. Okay, thyroid storm, hyperpyrexia, tachycardia, altered consciousness, hypotension. It's a medical emergency, and it can occur even in the euthyroid. Apparently, euthyroid there can be, if there is a sudden release of thyroid hormones. Okay. Active cooling, hydration, beta blockers, antithyroid, dantrolene may be used, and the airway breathing circulation approach. Okay. Okay. Any questions, please? I open some of. Where is it?
Sir, I just want to know, maybe in your hospital there is protocol. They are doing some intraoperative investigation, blood investigation, and also they send the sample, the frozen tissue sample, just to rule out the parathyroid. But they also take the 2 or 3 intraoperative samples. Do you have idea what they send? They will check the calcium level or anything else?
They do the calcium levels as well for parathyroid hormone. Actually, they do it for parathyroid. They do it for parathyroid. Okay.
Okay,
Okay.
sir.
So we will just Jamil, can you explain the thyroid hormone formation?
Sir, actually, it's regulated by the hypothalamus, the release of the thyroid releasing hormone. Then
Okay.
it goes to the anterior pituitary gland area. They excrete, there is thyroid stimulating hormone TSH from the anterior pituitary, and it's come to the through the blood to the thyroid gland. And this thyroid stimulating hormone, it will increase the absorption of the iodine from the gut, also from the blood to the thyroid gland. And
Okay.
then it's actually the iodine, it's come to the iodide forms, and at the gland level there is enzyme, what is the enzyme names,
Uh,
that kinase 9, I think, something
hydroxylase.
hydroxylase. And actually it's then iodide, monoiodide, it actually bind with monoiodide with di into 2. If the 2 monoiodide,
It's iodinase enzyme.
Iodinase. Yes.
That,
Thanks.
that
yeah,
catalyzes
Thanks for
into
yeah,
iodotyrosine and diiodotyrosine.
yes. If there is 2 monoiodines make us di, and if there is di and 1 mono, then it's combined and keep in the follicles as a triiodide. it deposit and then it's now and it's secreted as if two dye then is tetra like a T4
Yes.
tetraiodides in the form of
Okay.
in the hormones. Then it
Okay.
really is and it's go the tissue level, but it's its receptors inside the cell in the cytoplasm and in the nucleus level. In the cytoplasm, it's go to the messenger RNA and it will enhance the production of the proteins and it's go to the mitochondria. There it increase the uh, oxidation of different nutrition means
Like
the
it's
glucose in
like a powerhouse. Okay, it is acting
yes,
on the.
power of the cell in mitochondria, and if it's go to the nucleus, then it's help to regulate the DNA function.
Okay, okay, yeah, that's what you were telling. Okay, so we have discussed almost the same thing. Okay, thank you very much. If anything I have missed, I think we missed the anatomy part, how many in the lobes, what, please read about it because this question may be asked. It's a very simple thing. How many lobes, what is arterial supply, what is venous drainage, what is nerve supply, this one, what level of like vertebra it is there. Okay. So these are the questions and tracheal rings. Okay. So thank you
Okay,
very
sir.
much. So I hope you
Yes, thank
understand.
you.
If anything you don't understand, you are free to ask. Okay. Thank you very much. Assalamu alaikum.